Hi, Dr. Martinez, Lage.
Hi, apologies. I was having trouble finding the link for some reason.
Oh, I'm sorry. I'm glad you could join.
No, that's all right. All right. All right. Is everybody here that we're expecting?
Yeah, they will. They will keep on coming, but we can start because it's time.
It's time. All right. Sounds good. Welcome, everybody. Yep. Go. You can see my past presenter screen now.
Yes.
Beautiful. Okay, so what do we want to start with today?
All right. Let me open my list.
Yeah.
Okay, so we did choroid plexus. We did pituitary adenoma as well. We did not do medulloblastoma. We can do the infections, Toxoplasma, Cryptococcus, cysticercosis, and others. And we can do those neuronal. Yeah.
All right, so toxoplasmosis. I wonder if this will be, yeah, okay, that looks like brain. Okay, very good. All right, so infections are very, very interesting topic of the CNS. So Toxoplasma, worldwide and historically one of the most common infections in the CNS that will cause a mass lesion. Although frequently there will be multiple, so the type of process is going to be very similar to an abscess in toxoplasmosis. So the classical history would have been, someone that's immunocompromised with some focalized neurological signs and then multiple lesions on imaging. So occasionally you might have a biopsy of something if they haven't realized that the person is immunocompromised or something like that. So what do we expect to see? Toxoplasmosis are necrotizing lesions. So frequently you will have areas of tissue loss with neutrophils and macrophages. So here's, for example, an area where you can see quite a bit of macrophages in this background brain. And here you start seeing breakdown of the tissue. It's interesting that there's not a lot of what seems to be neutrophils in here, even though they're not unfrequently found in toxoplasmosis. So neutrophils in the brain, if you have neutrophils that are scattered in the neuropil, we call that cerebritis. But of course, when they become a solid nest of neutrophils, and that's abscess formation. And then what we're going to be looking for is, are there organisms that we can actually identify on H&E? These days we have a very useful immunohistochemical. Yes. Was there something?
No, I think that was an echo.
Okay, all right. So we do have a very useful immunohistochemical stain these days that sometimes it is actually very interesting because it will highlight a lot more organisms than what you think you're seeing on H&E frequently. So here are the encysted Toxoplasma forms. And then if you can see, some of these dots in the background are actually the non-encysted forms of rhodioids. So obviously things to consider are other types of infections, bacterial infections, for example. A lesion, looking at this lesion here, it does seem to have a lot of macrophages, right? Like a lot of these cells with quite a bit of cytoplasm. So when considering a differential diagnosis, if you only had this, the material in front of you, you should consider other things that can happen in a macrophage-rich lesion, right? So infarcts can be macrophage-rich in and of themselves. Demyelinating lesions, of course. But again, infections are almost always first in that differential. All right. So not a lot of organisms to be found really in that one slide. We can try to see if there's another one with more obvious. They can happen anywhere in the CNS, so supratentorial, infratentorial, it doesn't really have a very massive distinction. Here's an area of actual true necrosis, which is quite typical. And again, you see the inflammation in the area that are adjacent to the necrosis. And then you look for the organisms, they can be encysted or not. But the immunohistochemical stain is extremely helpful when you're trying to make this diagnosis. We use it relatively, generously. So if we have any type of lesion in which we're considering an infection, even if there's not a lot of necrosis, even if the patient is not necessarily immunocompromised, we do look for toxoplasma. Here's a cystic organisms. All right, so that's we can look for other Cryptococcus, for example. Oh. Cryptococcal meningitis. So in the same way that toxoplasma is typically a parenchymal lesion, most cryptococcal infections are going to occur in the meninges predominantly, and very characteristically will dilate the spaces around vessels. So if you have an autopsy of a patient that died with cryptococcal meningitis, you can frequently see that it looks a little bubbly. Particularly if you cut through the basal ganglia, you can see all these little, almost like a sponge pattern, and that's very typical of Cryptococcus. So similarly, this is a disease that more frequently than not occurring in patients that are immunocompromised, very frequent in the era of the AIDS epidemic. And what we're going to see are usually these, again, very rounded organisms with a capsule. I think this might not be an H&E, I don't know, because they're very visible, and most H&Es are hard to see. So I wonder if this is a different type of stain. There's obviously a sea of organisms here. So for people that are not familiar, every one of these forms with a very well demarcated capsule is a cryptococcal organism. They can elicit an inflammatory response, of course, but some of these patients, if they are truly immunocompromised, they might have very few circulating lymphocytes. So occasionally it looks paradoxically paucicellular in terms of the inflammation response. Here you can see some, potentially some plasma cells, maybe some lymphocytes responding to the Cryptococcus. The other thing is if you have an autopsy brain with cryptococcal infection, it will feel very slippery. So that's also another clue. All right, so not a lot more to say. So anything that occupies the leptomeninges, right, is considered a meningitis. This looks more like a surgical specimen because it doesn't really have very good orientation. So it's hard to tell what's where in here. Any type of, like this is collagen, these are collagen fibers. So we are probably in the leptomeninges here rather than in the parenchyma. So this would be expanding the leptomeningeal space. So remember that anything that occupies the leptomeninges can include organisms, can include cells in terms of inflammation, like autoimmune disorders, for example. It can include neoplastic cells, whether it's leukemia, lymphoma, or carcinomatosis, or even melanomatosis, or even gliomatosis. All of those things can occupy the leptomeningeal space widely. Are there any other meningitis here that make sense to visit? Let's see. So here is a section of the medulla. So from an autopsy, you can see All right. Okay. So this is the floor of the fourth ventricle here. These are the pyramids all the way here, and these are the inferior olivary nuclei. So it's an H&E stain. So the first thing that I can see on low power here is that there are a few areas that seem to be in the meninges that are dark and quite blue. So one here underlying the ventricular surface. So if we go a little closer, I'll focus here first. So here we have the ependymal lining of the fourth ventricle. You can see ependymal cells have all these cilia over there. So, and it is interrupted. So there is a lesion that seems to be eroding the surface of the ventricle. So this would qualify as a ventriculitis. And so what we're seeing are all these inflammatory cells that are occupying the space there. So some of these definitely look like they are multinucleated giant cells, right? So this one actually has the Langerhans phenotype of a multinucleated giant cell with all the nuclei disposed almost in a horseshoe-like appearance. Here, this is a good example of what a true granuloma looks like, right? So it's forming a rounded structure in and of itself, containing a multinucleated giant cell. So we have a granulomatous process that is involving the ventricle. And then here is another example of this granulomatous process involving vessels and the leptomeningeal space around the vessels, or multinucleated giant cells here, here, here. And so, you know, we suspect that that's probably the same thing that's going to be happening here, in which we were seeing that there's expansion of the leptomeninges again. Very good examples of epithelioid granulomas with multinucleated giant cells. So granulomatous meningitis is what we're seeing here. The question is, what is the etiology for these? You should definitely consider fungal infections, mycobacterial infections. So similar to any other locations in which you may have a granulomatous inflammatory process, you want to rule out mycobacteria, you want to rule out fungal, you know, whether it's aspergillosis or histoplasma or all other things. And once you've ruled out infections using the best of your abilities, then there's always a possibility that this is a sarcoid or sarcoidosis that is affecting the central nervous system. So sarcoidosis does affect the central nervous system not infrequently. It's not very common to have it as the only site of presentation of sarcoidosis. Look here, we can actually see the lymphocytic inflammatory infiltrate that is associated with the granulomatous inflammation. Here's a leptomeningeal vessel, here's perivascular lymphocytes. They all look mature, small, round, so more reactive than anything else. One of the most typical sites of involvement of the CNS by sarcoidosis is the hypothalamic hypophyseal axis. So very typically they will present with diabetes insipidus. But once it does affect the central nervous system, it can occur anywhere. So, and again, similarly to what you would do with any other organs, always bring up the possibility that infection is the underlying issue rather than being bold and calling something sarcoidosis. I think this is this. I don't think this is the same case. I don't know. This is another example of a cellular process that is involving the leptomeninges. I think here is a little bit easier to see. So this is cerebral cortex. We have the gyrus here, the sulcus here, and then the leptomeninges that are covering. And the process is predominantly lymphocytes and macrophages actually in this meningitis. I do not know necessarily that we know the etiology for this one. We don't, you know, bacterial meningitis more often than not will be predominantly neutrophilic, whereas other meningitis can be more lymphocytic. But again, there's a relative amount of overlap between those two. But again, so whenever you have something that is in the leptomeningeal space, make sure that you consider the possibility that it's a neoplastic process. For example, again, lymphomatosis, carcinomatosis, melanomatosis, etc. I think this looks just like fibrin rather than a true organism there. Something that you can see in meningitis is the involvement of the vessel wall as well. So that's not uncommon. Actually in bacterial meningitis, it's not uncommon to have occlusion of vessels and infarcts in the underlying brain parenchyma that are caused by the infection itself through affecting the vessel, the leptomeningeal vessels. Here's quite a few of these vessels that are being involved by the inflammatory process. Questions about meningitis? So neurocystic psychosis is the most, the quintessential nematode involvement of the brain, goes by T. solium. And in my experience, again, it is one of the most common causes of epilepsy worldwide. A lot of people have been infected by T. solium and can have relatively silent infection in the brain, but occasionally they do, the organism dies and they calcify, and even that itself can cause epilepsy. Cysts can be multiple or singular. And what we're looking for is these, basically these organisms that have this like very typical non-neuropil-like histology. There is, in this example, for example, it looks like we have an organism that is in the process of dying, where you can see the internal organs here, but it seems to be undergoing some degree of necrosis. And as you can actually see, there's already starting to be some calcification around it. I don't see a lot of brain around this particular cyst. So it might have been that this was actually an intraventricular lesion. Sometimes you can have them floating in the ventricles, but you can also see them embedded in the brain parenchyma. And occasionally when they are there, you can see inflammation. However, it looks like what we have here is all organism rather than background brain. This looks like it's pretty much the same slide. Yeah, I don't think we have a lot more to really explore there. What else can you think of in terms of infections? Are there any encephalitides here? I think they're all going back to, let's explore some of these. So meningoencephalitis refers to a process that is going to be affecting both the leptomeninges and the brain. And, you know, there are a number of things that can do that. What I was thinking about with just the term encephalitis, or so when you're looking at the infection in the brain, I talked earlier about when you have predominantly a neutrophilic process, right? You can have abscess formation, or you can have what we call cerebritis. When you have lymphocytes that are spilling into the brain parenchyma, we call that encephalitis. And it can be associated with a number of other features, specifically microglial nodules and neuronophagia. And that is a representation of, actually, that might be a microglial nodule there. Those are the typical features of chronic or subacute encephalitis that can be caused by viral infection. So arbovirus are the most common, or the prototypical viral cause of subacute encephalitis. There's a number of them: West Nile encephalitis, Eastern equine, etc. They all share quite similar histological features, in which what you will see are these perivascular coughing of inflammatory cells, most of which are going to be mature lymphocytes, occasionally plasma cells, but the majority are going to be lymphocytes by far. And then I'm just going to look around, see if there's any good microglial nodules. Microglial nodules typically or frequently will be associated with neurons. And so you can frequently see the neuron being directly associated with lymphocytes and microglia representing neuronophagia. So again, that usually happens when there is a neurotropic virus that is going to attack neurons specifically. One of the main differential diagnoses in the chronic encephalitis is going to be autoimmune encephalitis, and occasionally those are going to actually share a lot of the features. So it's not always clear cut whether a process is viral or autoimmune by just looking at the histology. So that's why these usually do need a lot of workup, including PCR, to rule out some virus as the etiology. We do immunohistochemical stains when we're trying to look for that. Here's a good example of a microglial nodule right there. So we have some immunohistochemical stains for some of these, but varicella virus, for example, many of those we do not have specific immunohistochemistry. You can send tissue to the CDC, and they might be able to also identify all of those things. But yeah, this is the picture of a encephalitis, and if there is significant involvement of the meninges, then you can call it meningoencephalitis. But yeah, here's another good example of a microglial nodule. So, why do we call them microglial nodules if they kind of look like they're lymphocytes? Well, frequently it's a mix of both lymphocytes and microglial cells. Microglial cells are basically invisible when the brain is in the normal state. They're there, but they're not very prominent. But whenever there's an insult, they become more numerous and more overt. And so they actually are characterized by these really long, elongated nuclei, sometimes a little squiggly. They were historically called rod cells because of that, because the nuclei look like rods. And they are, again, microglia are cells that have a little bit of a misnomer name because they are not glial. They are members of the monocyte macrophage family that emigrate to the brain during early development and live there as basically the resident histiocytes of the brain. Here's another example of a microglial nodule in one of the deep brain nuclei here. So very likely that what we're looking at here is a viral encephalitis, even though I could not really tell you which one. Okay. So this is a good one to visit. So this is not likely to be, but this is a fetal brain. So how do we know this is a fetal brain? You can see that there are, the cellularity of the cortex is a lot higher than what we've been seeing so far. During development, the neuroblasts arise from, around the ventricles, and then they travel all the way out into the cortex. And then once they arrive at the very edge, then they come back in terms of with the purpose of maturation. So cytomegalovirus is one of the members of the torch infection, so that affect fetal brain specifically. Most of those infections do tend to cause these. So they do tend to cause problems in what looks like development of the brain. So when these babies get to term, this is not a term brain, I don't think. They do have very small heads, so the development of the brain is stunted, and they tend to have periventricular calcifications. That's very typical. Toxoplasma is one of the other organisms that can cause that clinical presentation of perinatal encephalitis. So for cytomegalovirus, you're going to be looking at inclusions that are similar to the inclusions you see in other areas of the body with cytomegalovirus. So enlarged cells that might have intranuclear or intracytoplasmic inclusions. I think those initial ones are the most classical. Here's this glassy intranuclear inclusion and a very large cell. Occasionally, if it's been a little bit of time since the infection, the viral cytopathic changes are gone, and all that you have left is gliosis and calcification of the brain, which may mimic periventricular leukomalacia or a hypoxic ischemic injury in the development. But these are very, very nice example of cytomegalovirus inclusions in a developing brain. I don't know that we have an example of herpes virus encephalitis here, but that's actually a very characteristic pattern. Herpes virus, or HSV 1 or 2, causes encephalitis with a very specific tropism for the temporal lobe. So you will have a patient with a fever and usually seizures, and these are necrotic lesions of the temporal lobe. So they look almost like infarcts in the sense that it's predominantly necrosis. And that's very different from what I've shown you, the other viral encephalitides look like. See, here's an example of Eastern equine encephalitis, which is one of the arboviral ones that I was mentioning before. But we saw all those features earlier in that other case of encephalitis. Okay. Fungal infections, you can have, again, you can have aspergillomas, you can have long-term reactions that cause a granulomatous response to an aspergillus infection, and that can mimic a neoplasm as well. What you will see are granulomas with multinucleated giant cells, and you can detect the aspergillus by doing the usual special stains. Mucor, of course, can affect the brain by direct involvement from the sinonasal cavity, typically occurring in patients with diabetes. And that will also present as a destructive process that affects the vessels predominantly, and then the secondary ischemia of the underlying brain. All right, any other infection I should visit that you think of?
No, I think you covered very well.
Okay. All right, so looks like
next we can go to medulloblastoma.
Sounds good. Okay, so medulloblastoma, it's typically not primary leptomeningeal, and it is typically not in the skin, which is what this looks like. So let's find one that is actually a true medulloblastoma. So medulloblastomas are basically small round blue cell tumors that occur in the posterior fossa, right? So they are primitive tumors of neuronal differentiation. And they're going to present predominantly in children, predominantly with signs and symptoms of a lesion in the posterior fossa. So whether it's ataxia, headaches, increased intracranial pressure, all those things. Medulloblastomas are, in that sense, they're not very difficult to identify because you usually have, again, a child, a small round blue cell tumor in the right place. There are a number of things that we need to do to come to the diagnosis of medulloblastoma these days. One is histology. So this is all, you can occasionally see necrosis, you can see increased apoptosis, all those things are in the diagnosis of medulloblastoma. You want to maybe confirm that this is the neuronal process, for example, or a primary lesion of the area as opposed to a metastasis, for example. Well, you can do synaptophysin, which usually will stain the majority of the tumor cells. You could do, if you want to, but it's not necessary, you could do GFAP that usually highlights only background astrocytes rather than the tumor cells themselves. And then so before we get to that, there's one very important thing to do before making the diagnosis of medulloblastoma, which is to rule out something called atypical territory rhabdoid tumor, which is a different type of embryonal lesion or embryonal tumor that can arise in the posterior fossa and that can mimic medulloblastoma. So atypical teratoid rhabdoid tumors can have this morphology, but they have a different prognosis. And so the way to rule that out is to do an INI1 stain. So if you demonstrate that there's loss of INI1 in a tumor that looks like a medulloblastoma, particularly in a child that is 2 years or younger, but not necessarily limited to that population, then that is an ATRT, and it has a different prognosis than a medulloblastoma. So we do INI1 and it's retained. We do synaptophysin and it's expressed. So we are in the diagnosis of medulloblastoma. Then what else do we need to do? Oh, here it is. So I was looking for a little bit of maybe there's a little bit of neuropil formation here from low power. These look like they might be Homer Wright rosettes, in which you see neuropil in the center and then the cells around them. They're definitely not the best I've seen. But I think they might represent that. A synaptophysin can help you highlight rosettes if you want to see them. Obviously, again, they're not necessary for the diagnosis. So you can classify medulloblastomas histologically, or you can use molecular classification of medulloblastomas. Histologically, there is the classic type, which is something that looks like this, like a small round blue cell tumor that's not very architecturally, it's usually homogeneous. You can have Homer Wright rosettes, but not anything else, meaning there is no nodularity, there is no desmoplasia, and there is no anaplasia. So classic type medulloblastoma would be this. Then we have desmoplastic nodular medulloblastoma, in which it is actually characterized by the presence of islands or nodules that are typically paler than the background. And they're a little bit more mature in the sense that you have more neuropil, and that's why they are pale. The cells can have more cytoplasm than the neuroblasts that you see here. And then you do a reticulin stain, and it will highlight desmoplastic reaction between the nodules. So that's desmoplastic nodular medulloblastoma. Then there's a similar entity that's called medulloblastoma with extensive nodularity, in which you can see nodules, but they're not as well defined. And there's not a lot of reticulin staining in the intermediate areas. And then large cell or anaplastic medulloblastoma is characterized by abundant cell-to-cell wrapping and nuclear pleomorphism. Large cell can also have quite a bit prominent nucleoli. So those are basically the 4 histological subtypes of medulloblastoma. Then there are 4 major groups of molecular classification of medulloblastoma. So medulloblastoma, oh look, here's one that has some degree of nodularity. See here, we have these paler islands that are intermixed with these solid areas of tumor in between. You notice that the islands have this neuropil in the background. And again, this looks, maybe it could be a desmoplastic nodular or a medulloblastoma with extensive nodularity. This is a little bit unusual in that the nodules are more cellular than not. That would not be your typical desmoplastic nodular medulloblastoma, in which the nodules usually, again, are pale, like here, for example. If you were to do, for example, Ki-67, the background will be very high, whereas the nodules are usually a little bit lower because, again, they are quote unquote better differentiated. Okay, so 4 major molecular subtypes of medulloblastoma include sonic hedgehog pathway activated medulloblastoma, Wnt signaling pathway activated medulloblastoma, and then the others are called group 3 and group 4, or also known as non-sonic hedgehog, non-Wnt activated medulloblastomas. These groups were initially defined by protein expression, gene expression analysis and methylome analysis. In the upcoming classification, there are additional subgroups that can, I think, that can only be demonstrated by methylome analysis. So don't expect that you can always get to that precise of a diagnosis. So again, if you have a histological diagnosis, that's sufficient. If you have the ability to do some molecular testing, what we do is we do beta-catenin and look for any type of nuclear staining, which would basically signify that it is a Wnt signaling pathway activated tumor. And then you can do other types of immunohistochemical stain to help identify sonic hedgehog activated tumors, whereas group 3 and group 4 are usually identified by molecular testing of different ways. All right, and again, the reason that that's important is because the prognosis is going to be different for some of these different groups. For example, the Wnt signaling pathway activated tumors, particularly in older children, have a better prognosis than others. And then in the sonic hedgehog pathway, you actually want to rule out the presence of p53 mutations, because sonic hedgehog activated tumors with p53 mutations have a worse prognosis than those that do not have the p53 mutations. We were talking about ATRT, so let's see if there's one here. All right, so ATRT, a typical territory rhabdoid tumor, is an embryonal neoplasm that gets its name from basically the variety of morphologies that can present. I'm not sure that this example is going to reflect all of those or not, but it comes from, so the reason it was called teratoid is because it has different morphologies like that can mimic what a teratoma looks like. So in the sense that there are cells that can have GFAP expression and be glial-like, there are cells that can express cytokeratins and be epithelial-like, and then cells that can be synaptophysin positive and similar to a medulloblastoma, basically. It has the name rhabdoid in it because it is not uncommon to find rhabdoid morphology. However, as I was mentioning earlier, it is not necessary for the diagnosis of an ATRT. I'm trying to see if there's any here. We had some epithelioid looking cells here, but I'm not quite sure that I would say they look truly rhabdoid. We have some with prominent nucleoli, but again, so rhabdoid morphology is going to be large cells with a big cytoplasmic belly, so to speak, and a nucleus displaced to the one side, usually with a very prominent nucleus. ATRTs are characterized molecularly by, as I was saying earlier, loss of SMARCB1 or INI1, and a very small group of them can be characterized by loss of BRG1, which is SMARCA4. So there's two molecular subtypes of ATRT. Again, these are typically seen in children, and they are very dismal prognosis for the most part. And again, they do tend to present in the posterior fossa, but they're not limited to that location. It's maybe not the best example in the sense that we did not really have very good rhabdoid appearance. Ganglioglioma was in your list. All right, so gangliogliomas are tumors that have two pathways of differentiation. They have both a glial tumor and a glial component and a neuronal component. With the neuronal component typically being ganglion-like proliferation. So here is, this looks more like a PXA. Okay, here, this is a little bit more what I was looking for in a ganglioglioma. Okay, so this is a lesion that has these nodules. It doesn't always have to be this distinctly nodular, but it does help us. And so you can see that in the background, we have, not normal neuropil. We have atypical cells that are relatively bland but they are admixed with actual ganglion-like cells. So how do we define a ganglion cell? It has a large amount of cytoplasm. It has a big round nucleus and a big round nucleolus in the center. So what we're seeing here is way too many neurons or neuron-like ganglion cells that are in the background, sparse throughout without an organization. So that tells you that this is a neoplastic proliferation. And then additionally, in this case, we have these nodules in which they are even more prominent. So this is a gangliocytic proliferation. Typically in gangliogliomas, sometimes it might be a little bit challenging to identify these cells as being neoplastic. And one clue that you can have is if you find them to be binucleated. So that is a very typical finding of gangliogliomas, which is to have ganglion cells that are binucleated. Gangliogliomas are low-grade tumors. Actually, here's an example. This one has 2 nuclei. This one actually has 3 nuclei. So a feature of gangliogliomas are multinucleated ganglion cells. So gangliogliomas, again, they're low-grade neoplasms. They are characterized by BRAF mutation. So the majority of gangliogliomas demonstrate BRAF V600E mutations. There are some cases in which the glial component is not very obvious, and the majority of the tumor is just composed of the ganglion cell proliferation, and those can be called gangliocytomas. Prognostically, they have the same implication. So gangliogliomas are slow-growing tumors. They can be associated with epilepsy. They are one of the other characteristic lesions that appear with a cyst with a mural nodule on imaging. Typically are supratentorial, very common in the temporal lobe rather than other areas of the brain. Here's cortex. So we are potentially in the temporal. Anything else that might be interesting? Let's see what this is showing. Okay, so here's cortex. And here's one of these nodules that are very, very cellular. This is a relatively spindly proliferation of cells. So gangliogliomas can have these abundant, so things that are shared between gangliogliomas and other tumors, for example, PXA, pleomorphic xanthoastrocytoma, is the presence of eosinophilic granular bodies, which are these eosinophilic refractile globule-like structures, as well as the presence of perivascular lymphocytes. Those two things are very frequently seen in these tumors that are more or less well circumscribed, including ganglioglioma and pleomorphic xanthoastrocytoma. Both of those also share the presence of BRAF V600E mutations, as I was saying earlier. So going down the road of neuronal differentiation, right? We talked about ganglioglioma and gangliocytoma. So now we can talk about neurocytomas. So neurocytomas are going to be tumors of neuronal differentiation, but instead of demonstrating the ganglion cell-like morphology, they demonstrate this neurocyte morphology. So what are neurocytes? They are neurons that are relatively small and round in terms of what their nuclei look like. They tend to be homogeneous, and then they have neuropil in the background. So there's a number of things that this might remind you of, right? So one of the things that might come to mind with these really round looking nuclei, proliferation of cells in the background of neuropil, it might make you consider oligodendroglioma, for example. And in some cases, they can be mimickers of oligodendroglioma. There is this arrangement around vessels, so that on low power might make you think of ependymoma, for example. But you can see that the distinction between this perivascular pseudorosettes is that these are a little bit less defined than in ependymoma. There's like cells, nuclei are interspersed in all areas of these perivascular spaces. They're not as clean acellular areas, as you can see in ependymoma. So central neurocytoma is typically seen in the adjacent to the ventricles. And then extraventricular neurocytoma is the other designation of these tumors. These are, again, low-grade tumors with low rate of recurrence as well. They will typically have synaptophysin expression throughout the tumor and not very much in terms of GFAP. They tend to be well circumscribed, similarly to other lesions we've talked about that are low grade. And they can actually be almost entirely intraventricular, depending on the growth pattern. Sure. I see here. So Craniopharyngioma is an epithelial tumor of the midline of the CNS. So they are typically stellar or supracellular lesions. They're characterized by this squamous epithelium, and there's two subtypes of craniopharyngioma, and the differentiation is so important that actually the 2021 classification considered that these to be two separate entities rather than subtype of the same entity. All right, so looking first at adamantinomatous craniopharyngioma, these tend to be cystic lesions that are characterized by the presence of a squamous epithelium. Find epithelium here. Let's see if I find some of the features first before going down that road. They tend to present again with, here it goes. I think this one is better. Yes, definitely. All right. So adamantinomatous craniopharyngioma very typically is cystic. Very typically has this squamous epithelium with basal palisading that is admixed with these areas of loose stroma, also known as stellate reticulum, and then very typically demonstrating what we call wet keratin. So these pearls of ghost cells that used to be squamous epithelium that have lost their nuclei, and then eventually these areas of wet keratin become calcified. So adamantinomatous craniopharyngiomas are very typically cystic. As you can see here, there's a lot of cystic spaces that end up in a confluent cyst, and they are very typically calcified as well. Let me show you. Here's an example of an area of wet keratin that's starting to calcify in the center. I think I was mentioning the other day, yes, here it is. I was mentioning the other day how these tumors can create a response in the surrounding neuropil that is not infrequently characterized by the presence of Rosenthal fibers, which is what you're seeing here, all these thick eosinophilic structures in the background of increased cellularity. So it's an area of pyloid gliosis with Rosenthal fibers that is, again, associated with the presence of these epithelium with wet keratin. Adamantinomatous craniopharyngiomas are associated with alterations of the Wnt signaling pathway as well. So if we were to do beta-catenin staining, we would also see areas of nuclear retention of the protein in areas of epithelial tumor. Here's an abundance of Rosenthal fibers again. So again, so epithelium that is cystic with basal palisading in very pronounced in some areas, like here, for example. Wet keratin and stellate reticulum, as well as calcification and this reactive response of the brain. And you can see how these are very adherent in occasions to the brain. So even though the tumor per se is not a high-grade tumor, it's not an invasive tumor, it can create quite a bit of havoc in the area, and occasionally they're not resectable because of these the intimate connection with the underlying neuropil. So these are usually treated with radiotherapy in addition to surgery. So that's an adamantinomatous craniopharyngioma. Then we have papillary craniopharyngioma. So it is, again, a very different type. So papillary craniopharyngioma is also composed of squamous epithelium that's usually, excuse me, thicker than the epithelium that you see in the adamantinomatous type of craniopharyngioma. And then the growth is somewhat papillary, but notice how it's not very delicate papillary cores that you might see in other, papillary tumors. So these are almost arboriform-like areas of squamous epithelium overlying these relatively thick cores again. So that's pretty much all there is to it. There is no, there's no wet keratin. There is no, typically there's not a lot of dry keratin either. There's no particular palisading of the nuclei. They're almost never calcified. I mean, I guess they can be calcified, but they're not as frequently calcified as adamantinomatous craniopharyngiomas. And these are more common in the adults than in children, but they're not exclusive, just like a lot of other things. And they are characterized by BRAF V600E mutations too. So if you want to confirm that what you're looking at is papillary craniopharyngioma, you can do BRAF staining, BRAF mutation staining, and you will see labeling of the epithelium itself pretty clearly. This is a good thing for patients with this entity because actually they can be treated with BRAF inhibitors if there's, if surgery and radiation have failed to control the tumor. Okay, that's pretty much all there is about craniopharyngiomas. We have, okay, so we have pinealblastoma here. So pinealblastoma is basically an embryonal tumor of the pineal gland. So it's similar to what? To a medulloblastoma, for example, that we just talked about. Histologically, they can be very, very similar. So if you look at here, we have a very cellular tumor, easy to consider, small round blue cell tumor with quite a bit of pleomorphism, usually lots of mitoses, necrosis, apoptosis galore. So all the things that you associate with high grade embryonal tumor of the CNS. Because it is in the pineal gland, it is considered pineoblastoma. Again, these are WHO grade 4, similar to medulloblastomas. I don't think I said that specifically, but all medulloblastomas are considered WHO grade 4, even though at this point we know that there is a certain amount of difference in terms of the prognosis. So let's see, I'm not seeing an area where I could show you what the normal pineal gland looks like. We had mostly necrosis. This is an air. Okay, so this is neuropil in the background. Again, interestingly, with quite a bit of Rosenthal fibers, which is not very typical of an aggressive tumor like pineoblastoma we're seeing here. So then there are pineocytomas are tumors that resemble the normal gland, and they're a little bit similar to neurocytomas in the sense that they're usually round neurocyte-like tumor cells. They're bland, they're separated from one another. They don't have a lot of mitotic activity, no necrosis. And then there are tumors that are intermediate. They're called pineal tumors of intermediate differentiation that are between a pineocytoma and a pineoblastoma. It's hard to get into those without having good examples to really look at. Okay, so here's an area of calcification. That's something that you will expect to see in the normal pineal gland. So that might be a clue that that's where we are. The pineal calcifies with age, but it starts relatively early. But again, there's really not a lot of good normal background pineal here to use. So I think that's the only one there was there. Yeah. I guess we could mention chordoma since we're here. So we do see chordomas in the neuropathology world because they're tumors of the midline that arise from remnants of the notochord, and the most frequent location is the sacrum, but the second most common location is the clivus, and so that's why we do tend to see them. Chordomas are characterized by the a little bit too. Not what I would like to show. Okay, here we go. So they're characterized by this myxoid background that tends to be, you know, light blue as any other myxoid material, and they're admixed with cords of epithelioid cells that are usually eosinophilic, and they are admixed with larger cells that are vacuolated, and they're called fistulariferous cells. So I think there were a couple maybe here that were good for a fistulariferous cell. That could be one example. So there are lots of cytoplasm, ideally more vacuolated than that, and an eccentrically placed nucleus. Again, in a background of myxoid material and with other many eosinophilic epithelioid cells. Let's see, let's have better examples. Not sure where this is. It doesn't look like it's in progress. Okay, here's a better pattern of a chordoma in which you can actually see the cords, which are these lines of tumor cells that are elongated and then mixed with the stroma. And here's an abundance of fistulariferous cells in this background. Obviously, the differential diagnosis is frequently going to be with chondroid neoplasms, and so you can use cytokeratin stain. They're positive for cytokeratin, while chondrosarcomas should be negative. S100 can be positive in both of those, but the most specific staining is called brachyury, which is nuclear staining that is positive in chordomas. All right, I think that's all I can offer for today.
Yeah, that you covered everything very well. Not from me, and I think you covered very well all the list that I was able to gather. So I also want to tell everyone of who are attending that Dr. Martinez Lage has also accepted that she will go over some, you know, the new CNS classification. So it's coming. Is when we don't know yet, but it's coming. Be excited for that. We'll be getting the updates of the new CNS classification from her.
Right. Thank you, everybody, for coming.
All right. Thank you very much, Dr. Martinez Lage. Thank you.
Bye-bye.
Bye.